Hello, I'm Hunter Schultz, and this is Winning Healthcare Food Fights Without the Mess. On today's show, my guest is a family medicine physician in Marblehead, Massachusetts. He was the first direct primary care physician in that state. It was a terrifying experience opening that practice. You'll understand why. Plus, learn a little bit about how people are addicted to insurance. There's more to this than meets the eye. And we'll unpack it starting right now. Dr. Jeffrey Gold, welcome to the show.
Thanks, Hunter. Thanks for having me.
My newsletter subscribers already know why I'm excited to have you on. And it's kind of funny. I'll talk about that in a bit, and we'll get to that. But it was September 24th, you were in Charlotte, North Carolina for a pretty major event. And that was the announcement of the America First Health Plan or Healthcare Plan?
Healthcare Plan.
Healthcare Plan. And you were on stage with the president.
I actually wasn't on stage. I was in the crowd.
You were in the crowd. Okay.
Yeah.
So
some of my colleagues were up on the stage, though.
I was going to say, I hope your kids were impressed with Dad being in the same room, and they're a tough crowd these days. It's tough to impress them, but I would hope that they were like, "Wow, Dad, cool."
Yeah, it was pretty exciting.
So, who joined you there from the DPC community? I know Dr. Lee Gross, obviously yourself. Who else was there?
Yeah, sure. Dr. Lee Gross and the DPC Action crew were down there. There was also a lot of, people that I've connected with through social media that are physicians for, private practice, the American Association of Independent Physicians. I was invited through a personal friend who is a business owner in this area and is created an organization called Patient Rights Advocate. That is very big on price transparency in healthcare and has been very involved with, some of the pushing for a couple of the executive orders that have been signed over the past couple of years. So that's how I got invited down there, and it was pretty cool. I mean, like I said, I posted on social media, and obviously in today's political climate, you have to be we're so polarized. And I tried to explain to people that this is not, a political endorsement. I would have gone whether Bernie Sanders was speaking or whoever,
right.
Because I'm curious, to learn from all sides of what unfortunately is a political issue, even though I don't think it, I've never believed that healthcare should be a political issue, but unfortunately it is. And I'm always open, to hearing different views and, different sides of things. I think the truth always lies somewhere in the middle, with everything. And I really look at healthcare as a physician. I look at it as a nonpartisan issue. Unfortunately, that doesn't happen. But, it was a great experience to, kind of hear some of the things that have been accomplished, that don't get a lot of media representation. Also hear, about the pillars, of the health plan. So it was a pretty amazing experience to, at least be there and listen and learn.
The funny thing is, I've lived in Panama since 2004. And I've met people who left the United States because of Clinton, Obama, and Trump. But the interesting thing is, hence the reason of the show, Winning Healthcare Food Fights Without the Mess, I've found that if you talk to people, have a conversation with them, and focus on primary care, because most people are thinking healthcare is coverage and they get caught up in that, and that's where it gets really political. One side sees a black hole of spending, and the other side is looking at the compassionate side. What can we do for people that, for instance, have a rare disease? Do we just cast them out? I mean, no one really wants to do that.
Nobody.
We'd like to help those people, And Americans are an incredibly giving country. And living outside the United States, you get different views and different perspectives and the medical system here. People come here, and since I've been here, I've had on a business card for my doctor, I've had his cell phone number. People arrive here from the U.S. and go, wait a minute, what? It might have changed a little since I left, but you have access to care. That sounds familiar to anyone in DPC. So you get people talking about the care and what is great care. And the conversations all of a sudden, I mean, it's been remarkable that polar opposites come together instantly if you focus the conversation right.
Right.
So I get where you're coming from, and that's encouraging, because I think that's one of the things that if we get people talking about the care first, getting that right, and then have a path forward, a lot of the angst is just we're going to decompress quite a bit on many different issues. So from your vantage point, when you were there with your colleagues afterwards, where are we at with direct primary care? And what do you think?
I think that we're at a point where it's grown. It's grown across the country organically, probably not at the rate that I wish it were and some of my colleagues wish it were growing. But I think that I have not truthfully, I mean, obviously it's hard for me to give an unbiased opinion given that I am in DPC, but I have not seen any other change or proposal that I think meets what we call the quadruple aim of healthcare. The triple aim has been a term that's been thrown around, and that includes, the three tenets of patient satisfaction, better outcomes, and lower cost. But we like to add the quadruple aim of physician satisfaction, because the reality is if your physician is miserable, no matter what specialty they're in, you're not going to get the first three. So I think that there are a lot of very good physicians in primary care, other specialties that are very unhappy with the system as it is and just want to do the right thing by patients, but are very hamstrung given the middlemen and the regulation and inability to innovate. So I think that we're growing. I have very mixed feelings about exposure. And what I mean by that is practicing in Massachusetts, for example. I'm in a state where there is no direct primary care legislation, protecting us from departments of insurance regulation. About 30 other states have passed that. I think North Carolina was the most recent. And I mean, we're talking bills that are 1 to 2 pages long, that we're not insurance, plain and simple. But unfortunately, depending on politically who gets into office, whether, it's the next governor or whatever, I mean, I run the risk, and everybody else that's opened since I opened in Massachusetts runs the risk of basically being closed. Because if we have to pay regulatory fees, we just can't do it. There are a lot of states and docs that are protected. Unfortunately, there's a lot of states that aren't. But I worry about growing too big and too fast, because I think I have very mixed feelings about the government now being aware of what we're doing. And, Dan Crenshaw has been talking a lot about, his health plan, and DPC being a core of it. But I don't want to lose the direct as the tenet of what we do. And I think there is a role for government in direct primary care. And, we can talk more about how I see that happening. But I think that I'm worried about growing too fast and having eyes on us that may not be favorable eyes, and add regulation that little guys like me are not going to be able to afford legal battles and fights. But on the other hand, I love the fact that we're growing and that there are people that are in government and policy that are more aware of the work we're doing, more aware of the benefits of primary care. I mean, I think regionally, you have to almost take a step back and explain to the public what real primary care actually can do. I think, unfortunately, in my area, in the Boston area, which is so super specialized, I think there's a growing belief amongst people that, you need a specialist for every system of your body. And I don't blame them, because truly what they've been exposed to is a churn and burn 10-minute visit with what I used to do, which is I called myself a referralist, because I didn't have time to deal with anything that I trained to do. So now, you have physicians worried about the rise of mid-levels and nurse practitioners and PAs taking over primary care. But the reality is, if you look at it from the consumer lens, they're not really seeing a difference between the 2 years of training and the 7 years of training. What are we doing as family physicians in the insurance-based model that are really, making us stand out? And the reality is, in my opinion, not a lot. Now that I'm outside the system and I have the time to spend with people, I do the procedures that I trained to do in residency. I can manage the chronic disease that, I learned in residency, and the acute problems that I dealt with. Whereas in the insurance-based model, people are just not seeing what a real primary care physician can do and how important, that relationship is. I mean, the way that I look at it is, when I give talks to benefits advisors or companies or whatever, I always say that, if someone gave you $10 million to build a mansion on the water, would you build, with all these bells and whistles, an arcade, an indoor pool, a bowling alley, a gym, and put it on a foundation that's rotting with termites? You wouldn't do that.
No.
The foundation's not pretty and it's not sexy, but without it, the stuff on top doesn't survive. And that's literally what we've done in healthcare. I mean, we value primary care at less than 10% of the spend. And then we wonder why we don't have cost control, why we have so many, chronic diseases that are out of control. And it's when you're valued at less than 10 cents on the dollar, the rest is history. So I think what we're trying to do is rebuild this foundation. But the problem is, a lot of people don't understand the importance of that foundation. And that's where I think I'm going to step back, because I would say not education, but you actually have to uneducate first as to why what people are doing is not good and not working, both from a healthcare perspective and a cost perspective. Then you have to educate on why this is better on both accounts. And that's really, really the hard part.
So essentially, people are addicted to insurance.
Yes.
The fee-for-service model, they're addicted to it. And I would say that a vast majority, a significant majority of the country is essentially clueless about what great care is, primary care, and the role that primary care plays. And culturally, they haven't been exposed to it.
Right. It's very hard. That's the thing. It's very hard to blame them. It's learned ignorance that's just been, brainwashed into them. I mean, a great example that I use is, I don't know if you've ever read the book Dreamland. It was, about how the opiate issue, came into the U.S. And if you read it, the Mexican cartels had the best business model going. They had these on the ground soldiers go into the U.S. into cities and basically give their product away for free. And once you give that product away for free, you have a customer for life, because they're now addicted. And what we've done is we've gone to this system where, for the past 6 decades or so, we've looked at health insurance as a way to pay for healthcare rather than actual insurance. And I always say, I'm not against insurance at all. I'm not anti-insurance at all. I think insurance is a huge component of protecting people in healthcare. Mm-hmm. But I don't think it should be used for dumb things. And I think what I mean by dumb things is that basically the two things that I always say to people is that they've been brainwashed by the government and the marketing of the insurance companies to think two things. Number one, everything in healthcare is so expensive that if you don't use insurance for it, you'll go broke. And number two, which is kind of a corollary of it, is that if you don't have insurance, there's no way that you can get good, affordable, quality care. Both of those are BS. And unfortunately, people don't know that. So when there is, we talk about all these value-based, contracts and payments. Well, yes, you can look at knee replacements in facilities and look at value and look at, outcomes and complications and all that kind of stuff. But really the only determinant of value in primary care should be the person that's actually on the receiving end of the care. And unfortunately, that person, the patient, has been actually extricated from the transaction almost fourfold, because then you add employers as another layer. So it's like you have patients, you have doctors, you have the insurance and government in the middle, and then you also have another layer of employers. So when the consumer is using an insurance card as a credit card, and they're not realizing that, that $10 copay that you're paying also has, a 99,000% APR on it. You're now in the situation we're in where insurance is actually becoming more insurance-like, and people think that they have terrible insurance because it doesn't cover everything. But if you ask somebody what's good car insurance, they say, I pay an affordable premium, I have a deductible, and I'm protected in case I'm in a major accident. But then ask them what good health insurance is, and this is pays for everything. So it's that dichotomy and that split that we have to fix. And like I said, it's hard to blame patients, because this is what they've been fed over and over and over again. It's to put it bluntly, when people ask me like what my thoughts are on on how to understand the U.S. healthcare system, I ask them if they have Netflix. And most people have Netflix. And I say, have you watched Narcos? Some people have watched it, some people haven't. I don't know if you've watched it.
No,
but basically,
I watch, but
yeah, it's historical fiction on Escobar and the Colombian cocaine cartel. Only difference between the U.S. healthcare system and what Escobar did in Colombia is just the product. That's it. There really is no difference.
So how do you break people? Well, couple thoughts. As you were saying this, I'm thinking car insurance is a great analogy. You'd think, oh yeah, I pay for oil changes with my insurance card. Huh?
Right.
Well, why would you do? No one would do that.
No one.
And no one would pay for tires with their insurance card.
Right. And no one would mow. And no one would mow their lawn using homeowners insurance.
That's a good one. I have not heard that one before. When I ask people culturally, when you think of healthcare, what do you think of? Say TV shows. You mentioned Netflix. Americans will mention things like Grey's Anatomy, ER, House, Chicago Hope, and there are probably a few that I'm missing, but they all have something in common. They're all hospital-based shows.
Right.
Hospitals have to love that. I mean, they have to love it because it reinforces, to get great health care, you have to go to the hospital.
Right. You can't do anything in the outpatient setting. It's all in the hospital.
Right, which is absolute nonsense. So let's get back to something that I think is I know you're all about. How do you get people, if you're in addiction recovery, I've had Molly Rutherford on the show, and she mentioned Dreamland to me. She said, read it. And I said, okay, good. And it was great.
Well, she practices in an area that's been really, really hit by that.
Yes. Oh. If you're an insurance addiction recovery expert, how do you do it? How do you unpack it for them to get them to realize?
Honestly, I wish I had the formula, because if I had the formula, I'd be talking to you from my yacht. But I think the way to do it is exactly very analogous to how healthcare should be delivered, which is on an individual basis. And I think that's the hardest part. It's very labor intensive, but I think everybody's needs are different. Everybody's understanding is different. Everybody's family history, medical conditions are different. Their social determinants are different. And that's why I think, everybody talks about how we need better population statistics. And I'm like, well, populations are made up of individuals, and we're doing a pretty crappy job taking care of individuals. So how are we going to get good population data if you don't take care of the individuals and meet them where they need it? So I think it's very analogous to, literally sitting down with them, and also finding people from other areas of, health insurance, benefits advisors that, are outside the box thinkers and are not just looking at their commission, but looking at, building relationships with families or business owners that, is based on trust. And I think that that's the biggest difference is, we really have to look at everybody as an individual. There's people who if I had a patient come in here to meet with us for a free consultation, which we do, and they tell me they just lost their insurance and they need insurance, but they also just got diagnosed with breast cancer. There is not one broker or physician in their right mind who would advise that patient to go on a high deductible health plan that year, because clearly you have a condition that you're probably going to meet your deductible in a month, with surgery, treatment, all that kind of stuff. But then for someone who's 35 and completely healthy, why do we not have an option of even a higher deductible, lower premium for people like that? The great example of how I explain to people that what we have is not insurance in healthcare is this. If you look at what the typical price, global fee for a colonoscopy is, okay, so including sedation, procedure, everything, not done in a hospital, but in a outpatient facility, it's anywhere from $1,000 to $2,000 is what it costs. Now, say you're an average 50-year-old American, you have no family history of colon cancer, and you need your screening colonoscopy. Okay. Would you rather, if you go in and it's negative, you're good for 10 years. So if you take that $1,500 and spread that out over a 10-year period, do the math. Not a lot of dough. But if you go in and have that colonoscopy, which is free under our insurance model in the US, and you have 3 polyps biopsied, where a majority of people now are on high deductible health plans, you're now expected to pay the expensive part of it. Wouldn't you rather pay the $1,500 and then be protected against the really expensive stuff downstream? Same thing, think of a mammogram. Mammogram's $250 a year, $250. So that's covered and that's free. But if you have a lump or a mass that you end up needing a needle biopsy, diagnostic ultrasound, people on $3,000, $6,000 deductibles are now exposed to that. Insurance would work the other way around. So you have to take it, the short answer is I think you have to take it on an individualized basis. And that's a very, very hard thing to do. And that's where I think it all starts with the relationship is if you look at statistics, most people between the ages of 30 and 50 either don't know who the hell their primary care doctor is or don't even have one. And, think of, this is the stuff, that I see all the time when I was a kid growing up. If you tore your ACL and you needed an orthopedist, you called your primary care physician. You say, who do you recommend? Who do you use? Who do you think's a good doc? Now go on Facebook and there's people asking in Facebook groups. Why? Because they're disconnected. They don't have a relationship with a primary care physician who they trust. It's doc in the box, urgent care. We've taken this relationship-based medicine, which is very, very hard to put a value on, and we've turned it into a bunch of transactions. Yeah. So when you go to get your ACL repaired, is it great if your orthopedist, if he or she has a great bedside manner and is comforting and caring? Great asset to have. But really all you care about
outcome
is that you're going to get off the table and is your knee going to be fixed? And you hope you never see that person again. Because if all goes well, you shouldn't see that person again. But that's not how primary care works. And the only way to make it work is to establish that relationship. And that's where I think the education can come in. You know, concierge medicine has been given a bad connotation because of, you know, the price associated with it, or it's supposed to be for the elite. But the term concierge actually really fits what a primary care doctor is supposed to be. We're supposed to be your concierge. If there's something that is out of the scope of our care or our training, we're supposed to guide you to the best place that we advise. And unfortunately, cost has never been considered in that.
Yeah.
Now we consider cost as a DPC doc because we know what things cost. I always say we have the only service industry in the country, maybe even in the world, where the person receiving the care on the transaction side and the person giving the care on the transaction side at the time of the transaction have no idea what anything costs. I can't think of any other industry that functions like that.
Or would be allowed to in many cases.
Right.
Even in the U.S.
Right. So now what's happened is insurance is becoming more insurance-like, and you have people on these high deductibles. But the difference with the car insurance is you can go online and you can look at Jiffy Lube. You can look at your dealership to see who has the best price on an oil change. How do you do that in healthcare? You want people to be consumers, but yet they have no ability or tools to do that. And really, a lot of that should be a mutual discussion between patient and doctor. You know, medicine's the only field, you know, if you go buy a Porsche, if you go to a Porsche dealership, you know you're going to pay Porsche money, but you know you're getting a Porsche. In healthcare, you can go spend Porsche money, but basically get a Yugo.
I used to sell Ferraris when I was a kid in my 20s. So right. I know I get, there's a great, the thing we're also doing is we approach insurance with, we'll go get the insurance, pay an insurance premium for a Ferrari, but we're actually getting a Yugo.
Right.
Because we buy the insurance first, and then we're forced to look at the care. And even then we're clueless, and it's the ignorance that.
Right. And that's why I really feel that the top down approach has not worked for decades.
Can't.
And until people realize that the only way we fix this is from the bottom up, and it's really about doctors and patients. And, you know, the reality is we're all patients. And I think until people start, you know, I always say that if you look at an employer, or then you look at a family and you look at their budgets, on this side, number one on the line item, salary. Number one on the line item, usually rent or mortgage. Number two, and on this side, sometimes the health insurance is even more than the rent or the mortgage. And yet people spend more time searching for a flat screen TV than they do what their second biggest annual expense is. And part of that, again, is not their fault, right, because it's been made so complicated and so confusing, you know, that they're just like, oh, if I get it through my employer, just let them figure it out. Meanwhile, not understanding that maybe they can keep that money in their paycheck, take that money and maybe go buy, you know, a sharing group or, you know, a lower premium, higher deductible plan that may be cheaper than what their employer is offering. It's so convoluted that in their defense, they can't spend the time on it. So it's just left to, you know, other people's choice and devices. And until they become more of an active participant and demand that, I don't see much changing, sadly.
The thing that I see in direct primary care is corner. There are two things that I hit on. The personalization of medicine, which you've been talking about in a different not a different context, but everyone is different.
Right.
And it takes time to unpack that. You know, you get to put on your medical Sherlock Holmes hat and connect dots, but that takes time. So too, your other ace in the hole, if you will, is privacy. And there's nothing better than having a direct primary care physician for the privacy alone.
Right.
Surveillance of electronic health records is an addiction for insurance and government and 2 million other entities that have access to this data.
Right.
And that's frightening to me. And I don't know if you've ever seen the movie Gattaca.
No.
Oh, you check it out. Because that could be a sales tool for you. It is a frightening scenario. It came out in 98, a few years after HIPAA. So the other thing I did want to mention very quickly, two things. Number one, I wanted to give you guys a lot of credit in terms of the DPC community for getting into the White House, getting into the fabric there to get DPC on the table. Because I know a lot of your colleagues and you and others, that's difficult. That is not easy to do, and bravo. I think down the road people are going to say, wow, that was amazing and great job. And I'm curious, were you in on any of those discussions there?
I haven't been right, in the heat of the discussions. I mean, I think DPC Action's been more involved in that. I have been down as part of the, Direct Primary Care Coalition, a couple of years ago, trying to, support the Primary Care Enhancement Act to fix, the HSA issue. But I can tell people it's pretty messy down there. And you need a lot of time and you need a lot of money to get anywhere. I'm still involved, but, I think my primary focus is obviously on my practice and my business and my patients. It's really sad, again, that it's even a political, issue, and trying to, you have a federal bill, the ACA that, right in there says that direct primary care is a, primary care medical home and not, insurance. And yet we have an IRS and Treasury that, won't allow HSA use because it's a health plan. So it's, it's a mess, and I literally wonder how anything ever gets accomplished down there. So, I felt like, look, we have the people, that are lobbyists that have the time and the money and the skill and the knowledge to navigate that mess down there. I put my 2 cents in as to how I could see DPC blending into a Medicare or Medicaid type model. It unfortunately, the rule makers are also the players.
And they don't have voters knocking on their doors saying, what are you doing? Because they don't know.
Right. And
they don't know enough.
It's a tough game to win when you're playing against the people who are actually making the rules.
Yeah, the pros, so to speak.
Right.
I just wanted to mention that in the newsletter that went out on October 1st, I gave the newsletter subscribers this insight as to why I was so happy to have you on the show. And the long story short, I'll telescope some time here. I was working with some high-end medical services here in Panama, representing them. And one of my medical mentors actually was a White House physician. So I learned a lot about care, and I learned a lot about the thinking behind the care. And so during this process, I started thinking about, well, how could we get this thinking, this level of care? You strip away the security and the round the clock steps away care. How can we get that to the masses? Because boy, everyone should have this.
Right.
And so I started thinking about, well, how do you actually do that? And the membership business model to me was the key, because we used it in air medical transport and life flight business here a long time ago. And it solves a lot of issues, cash flow being one of them. So I started thinking, wow, this is a really good alternative, and I'm getting excited about it, more excited. And I think, okay, I got to come up with a name. And the name I came up with was Primary Direct Care. I was like, oh God, this is great. I was so excited. And I go on Google and I put in primary direct care. Google says, do you mean direct primary care?
Yeah.
Oh, click. And what did I find but an article? It was one of the first results that I saw. It was an article about a doctor in Marblehead, Massachusetts named Jeffrey Gold doing exactly what I was about to do, or doing exactly what I had thinking.
Oh, wow.
My eureka moment went, drats, darn, I cleaned that up. So you were actually the first physician that I ever found that, you know, we're thinking alike. And then
luckily there were a lot of people before me that, you know, the Blisses with Q Alliance and Alice MD, and you know, there were a lot of people before me that, you know, led the way, and it's I'm very grateful for them.
Yeah, that's the community that I've had these discussions with, including your buddy Doug Farrago.
Doug's the best.
We had a good conversation last week, and I think you just gave me some ideas in terms of being careful about how essentially flying direct primary care under the radar screen. It can't be. I was thinking about, why didn't President Trump, in his remarks, he didn't mention direct primary care, which you were probably breathing kind of a sigh of relief. So that's something that needs to be explored further. How do you fly it under the radar screen? And DPCstories.com, which the Alliance is working on now, getting more stories out. And again, I'm standing by. I can't wait to talk to patients. I talked to Eric Brown, one of Doug's patients, and they are one of the best organic sales tools that you have.
Without a doubt.
You know, I think the more we can get them on the air, so to speak, and be able to point people, amongst other things that are going on, they're the best marketing and sales tool you have, because they're really talking about how life has changed for them. For many of them, their life has completely changed. And I've heard the stories from docs on the show. So I want to go to Gold Direct Care. I mentioned it was 2014, the article. You opened in January or February 2015?
Yeah, early 2015. So I was going to open, you know, very early in January after I left my employed position, but we had a winter from hell up here that the build out of my office was delayed because of blizzards. So we, you know, kind of officially opened in February, but I was here, you know, seeing people with an office under construction probably wasn't the safest thing to do, but yeah, so that's about the time that I opened.
You mentioned in this article, and I'm going to read it, you said opening the first private direct primary care practice in Massachusetts is terrifying. And looking back, was that terror justified?
Oh, without a doubt. I mean, I think that, you know, there are like Dr. Fernanda Poulet, who, you know, runs Iora Health, which is based out of Boston. He actually tried to do something very similar, you know, years ago, you know, because of insurance regulation and government regulation. He basically was closed down and went to do Iora, you know, because it's ERISA and it falls under federal rather than state. So when I was actually at my old job, still working there, and was contacted by the deputy commissioner of insurance because one of my former neighbors was a writer for the Salem Evening News and said he would do a story on me. So came down to the office, took some pictures of it under construction, did a story on me. And of course, it magically, you know, showed up on the deputy commissioner of insurance's, email or desk, and I was called before I even opened asking me, what is direct primary care? Is it insurance? Should it be regulated as such? What am I doing? So a boatload of legal fees later, we argued that, this is not insurance. People are not paying me $80 a month for me to do brain surgery and invasive procedures that are expensive. The only financial transfer of risk to me is if people don't sign up. That what we do in primary care is not expensive. And, I always say we've made it expensive by insuring it. So, I think that I got a nice letter from them directly to me advising that, our patient agreement has X, Y, and Z. And, we're very careful. We have a waiver in our packet that if we do have people who come in that have no insurance and we offer them to meet with our benefits people to help with that, and they say no, we have them sign a waiver that they understand we are not insurance. We're not going to fix their broken femur ethically, morally, and unfortunately in Massachusetts, legally, where we still have the mandate here. We have to advise people to have insurance, just the right thing to do. But yeah, it was terrifying. I mean, I worked for 8 or 9 years in the system. I had about 2,500 patients, and I looked and said, okay, it takes about 600 to 1,000 to make DPC work. And I fooled myself into believing that people valued me as much as I thought they did, and thought that I would have 400 or 500 of my core people that I had taken care of for years come with me. I mean, especially given, what I was charging $2-3 a day or whatever the heck it was. And I only had about 100, people come with me right off the bat. So, I mean, I almost had to rebuild from scratch. And, some of them trickled in later on, and they had what I call the catalyst. And that can be anything from as simple as having an appointment rescheduled for 9 months out, or having something as severe as, bad care or misdiagnosis, or, and then they end up coming back. But, it's been a very, very challenging thing to do in a market where, again, I don't think people really understand the capabilities of what we can do here in Boston with primary care. There's also a very heavy, Partners Healthcare, which are the Harvard hospitals, is the biggest employer in the state of Massachusetts. I think there is a lot, truth be told, the people closest to me, were the ones that were consistently, I modeled a lot of my practice after Atlas MD and Dr. Umber. They were, very helpful, and I used their software. And all I kept hearing from the people closest to me is, Jeff, this isn't Kansas, right? And I'm like, I know it's not Kansas. And there was a risk that I could completely fall on my face. And luckily, I was told by my former boss that this wouldn't work in Massachusetts, directly to my face. And here I am, 5 years later. And did I take a mortgage out on my professional career? Yeah, I have an angel investor who helped me, cover my salary the first, couple of years. So I was fortunate enough that, unlike a lot of other DPC docs that transition, they have to do moonlighting jobs and maybe a hybrid model until they get up and going. I was fortunate enough that I had a very favorable, patient of mine who really believed in what I was trying to do here, and gave me a line of credit that I could build the office out, cover my expenses. And, I pay, he takes 75% of the profit until I pay him back. And it's not the easiest thing to sit and think about. But I look at it like, at least now I'm practicing medicine, and everything I do is to try to help make this system better for patients and doctors. And I'm not just sitting there entering codes and practicing paperwork.
Yeah.
I don't understand, when you look at that addiction brainwash model, it's so clear, because when patients are okay with waiting 45 minutes in an office for an appointment that they probably didn't even need to have in person, to get a refill on a med, be seen for 5 to 10 minutes, if lucky, and then, get a bill for $300 because of the deductible, and yet they keep going back to the trough. It shows you how ingrained, and if you read the piece that I wrote last year on this issue, I actually put a dialogue that I had in there with a patient. And, the way we work with our lab work is I'm still on staff at the local hospital. And I say to people, look, this is our negotiated lab pricing. We tell them what it is right up front. And we say, if you want to use your insurance, though, we can have the courier from the local hospital pick it up and they can bill your insurance. But I say, if you have a deductible or copay, it's not going to be my responsibility. And the patient says, well, how much my lab's going to cost? And I said, $20 in total. And he said, well, I pay a lot for my insurance, so maybe I should just use my insurance. And I said, well, do you understand that the reason you pay a lot for your insurance is because you keep using it for things? And his response was, well, I'll still use my insurance. So $20 value put through layers and layers of red tape. And then these are the same people who will come back and complain about their premiums and deductibles going up the next year. So you multiply that exponentially across the country, the people are doing that, and you wonder why the insurances, they're just sitting there having parties, because it's just, the more claims they file, the bigger their pie is, and that 80%, 20% MLR looks really, really good to them. So I always say, benefits advisors that get it say, hey, today's claim is tomorrow's premium, copay, or deductible. There's no free ride here.
Yeah. I got an education from Carl Schuessler Jr. on benefits. He's a benefits advisor.
Yeah.
Fair cost health plan. I've seen, and I think COVID-19 has been a real battering ram. It's been sensitizing people to the fact that they didn't have, wait, you mean I didn't have to go to the office for this? You could have just done this over the phone or via video call? How come? Well, it's the way the system works. You have to come into the office for me to be paid. Oh, right. So there's an opportunity here. But one of the outgrowths from this, and I've seen this on one of the direct primary care groups, and more doctors are going on that group and saying, hey, I've been hearing about this, and how do I start? And some of them are saying I'm going to start from zero. And Dr. Rebecca Behrens, who was on the show, she started from zero. So what would you say, what words of wisdom would you have for those docs that are in the old system and are going, okay, I've had it. I got to do something, but I'm scared. And what words of wisdom, what kind of motivational paragraph could you give to them?
Well, it really is hard. And I mean, I did it. And like I said, my situation, is unique. I had a very favorable loan agreement, and a lot of help. And I think the best thing you can do is whether you have a partner, spouse, husband, wife or family member, friend that, has a good business head or, an accountant or whatever. I mean, use the people around you that, support you that, we're not trained marketers. We're not trained businessmen, which is a whole nother, issue with medical training. People leave residency of any field and they sign an employment contract and insurance contracts because it's guaranteed income, and you don't have that here. And part of what I'm trying to do, with benefits people is, build a model where, we can help risk averse docs. Part of my mission is to save docs, and help them have a crux, a foundation again to get out and have the ability to function and not go through that scary piece. But it is scary, but I think people can do it. If anybody can do it, I can do it. If I can do it, anybody can do it. I mean, I had no business sense whatsoever.
Boy, have I heard that before.
Yeah. And, but I think, there's a lot of free resources out there, the DPC Alliance, Atlas MD, there's plenty of resources out there. Reach out to a doc like me doing it or someone in your area that's doing it, shadow them, learn from them. I think the best thing about this whole move for me is the collegiality that I've seen. I felt like I was operating in a silo. I had partners in my office that I'd go a week without even seeing. Whereas here, even though I'm on my own with my partner, Dr. Mancini, I feel more connected to people, and more physicians than ever.
Great community.
it's a really good community. And, and I think the sad thing, and I, going back to the work that we have to do to get this message out there, it's pretty telling. You mentioned the COVID issue, and there's been a lot of articles, even from both sides of the aisle saying, how COVID has destroyed, some independent primary care practices. And I say, hold the phone. And I wrote a piece about this too. I said, COVID is not destroying anything. It's shining a light on what was already broken. My buddy Vance Lassie, he's a big meme guy. And, when we were reading all this stuff about, the government's relaxing regulations on telehealth and they're going to reimburse for it, blah, blah, blah. We did a meme where it's a picture of Congress, with all this, saying all this stuff. And then it was a picture of us at the DPC Alliance basically saying, hold my beer. We've been doing it. We've been doing it for 5 years and more.
Great meme.
But the reality is I reach out to press all the time. They just want to continue to report the problems. They don't want to report the solutions, and, I'm not saying DPC is the only solution. I think it really can be if done right, but it's certainly an option that should be getting more national press than it is, because when you think about it, if you look at any field in healthcare, any doctor group, we're really the only group of physicians that are risking financial loss, professional, stability, income, to do what we think is the right thing to rebuild this system. No other group of docs are doing that. I mean, there's organizations and, they talk, but no one has really taken the lead. And, the reason I did it is, truthfully, I actually got sick of listening to myself complain. I said, you have two options here. You either stay in the system and know and accept what you have and do the best you can with it and try to make the most money that you can, or shut up and make a change. And the only way that I could do what I wanted to do, sadly, was escape the system. And there's a great, Buckminster Fuller quote, who's an architect, famous architect. And it's something along the lines of, you don't make change by, kind of altering what you have to build a better model. You tear down and rebuild, something along those lines.
Absolutely.
And it's one of my, make it obsolete. And it's literally what we have to do. And, a PR person that I talked to when I first opened gave me great advice. He said, Jeff, majority of politicians, he used to work in Beacon Hill in Boston. He said, majority of politicians, what they really care about is votes. And he said, if you build something that the constituents want and like and don't want taken away from them, no one's going to do that. And that gets back to us being under the radar, because if there's not enough of an army and the regulators come in and say, hey, we don't like this, then a lot of us are in a lot of trouble. And that's why I think, mobilizing an army of patients like you talked about, that really people don't want to hear, even though it's not the truth, people still think, we're making six figures. We're whiny docs. No one wants to hear from us. They want to hear from people. They want to hear from people who, the only thing that I really get fired up about from the naysayers of DPC is when they say, we cherry pick. A majority of my patients are people that the system has chewed up and spit out. So that's the only one that literally, you want to get my vitriol going, tell me that I'm cherry picking patients, because that will, and I think you've probably heard that from a lot of us.
Yes.
Yes, we have patients. The beauty of this is we have patients from all walks of life. I have people who, said, hey, I'm going to drop my premium, and go up my deductible. I'm not a frequent user, but I'll pay you the $75 a month. And even though I may not come in more than once or twice a year, I'm still where I was, but I know I have you available. It's a zero sum game. They don't lose, but they gain. So I think that, there's so much we can do. And I wish I had all the answers on how to do it. Cause like I said, if I did, I'd be on my yacht right now. But I think that the beauty of it is, if we ever do get to the top of the mountain and DPC becomes more of the norm rather than the niche that everybody wants to put it in, it'll really be gratifying.
If someone was out pre-selling DPC, If I could say to a doctor, hey, doc, I've got 250 people ready to go, or 300 or 500. Yep. Is there kind of within the community, is there a number that you guys kind of say, well, if you bring in 200 patients, you're golden to start, to get going?
Yeah, I think that's a reasonable number. I mean, I think if you can get, kind of like 300, that's a really good cushion, to at least get it off the ground. Obviously, as you mentioned, my rent here is a joke. It kills me where I am. I mean, my dear friend, Kissy Blackwell, who's in Wichita Falls, Texas, whenever we see each other, she rides me that she pays $1.50 per square foot. I pay $43 a square foot. So, my rent makes me have to take more patients than I probably would want to. But I think across the board, if you can start off with around 300, no matter where you are, I think that's a really good baseline to grow off of. And that's what, again, I'm trying to do is find ways to get the lives. We have the biggest issue right now is chicken or the egg. You go to an employer who's got 500 employees and they're like totally sold. They're like, we want this, but we've got people all over, right? Where are the docs? We got to find them.
Right.
But the docs won't leave the system to do DPC or come out of residency doing DPC unless they're crazy like me, or they have a guarantee. They have a guarantee of that 250, 300 patients to start with. So it's like, where's the breaking point? It's got to break at some point, whether that's finding the one big employer who says, we want to do this, and everybody starts watching, or, you keep growing organically with smaller businesses and individuals and families that decide it's for them. But I think the 250 to 300 is probably a very good baseline to start with.
Good to know. I have the DPC Sherpas that I'm winding up. First Sherpas out there now. And it's trying to find a doc.
Right.
That is part of it down in Okeechobee, Florida. Dr. Jeffrey Gold of Gold Direct Care, it's been a pleasure and to meet you at last. The first DPC doc I ever became aware of is you. So what a thrill it is for me.
Well, thanks for having me, Hunter. And I'm always, happy to come back. As you can tell, I like to talk a lot. So if you ever want me back on, if people aren't sick of hearing my voice, I'd be happy to come back on and talk more about, other things we maybe didn't cover.
Sure. Well, for Winning Healthcare Food Fights, I'm Hunter Schultz. Stay healthy, wash your hands a lot, and there you are.